We provide education to our coders. And on the flip side of that, they tell us what we're missing in our charts. It really is a collaborative both ways for us, so that we capture the right acuity.
Change is tough for any system. I think the beauty of a good service line is we got to be open and prepared to adopt workflows that are going to work best for the patient.
When it comes to cardiovascular care on the organizational level, MedAxiom understands the challenges your program is facing. Welcome to MedAxiom Heart Talk, the podcast where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom Heart Talk starts now.
I'm Melanie Lawson, a journalist in Jacksonville, Florida, and host of MedAxiom Heart Talk. So far in this series, we have covered how to clinically capture the acuity of TAVR patients and how to save thousands using templates embedded in your EHR. In today's Structural Heart Innovations episode, we will explore standardizing acuity capture across the service line. Today's guests are both from Prisma Health in South Carolina. We have Susan Lowe, Executive Director of Cardiovascular Services, and Jim Kreiner, Director of Cardiovascular Operations. So welcome to the podcast, both Susan and Jim.
Thank you, Melanie.
Yeah, thank you. I'm glad to be here.
Well, you both have extensive experience and expertise in this field. So I do encourage everyone, read their bios in the episode notes. They're available for you. But we do want to kick this off. And the first question I love to ask all of our Heart Talk guests, because it really gives us some insight into who you are and why you decided to get into this industry. So why did you decide to get into healthcare? And Susan, we'll start with you. Did you have that aha moment at some point in your life?
I would have to tell you my aha moment was my entire life. I grew up carrying around a nursing bag thinking I wanted to be a nurse. At 16 years old, my father was burned over 75% of his body.
Wow.
And I spent a lot of time in rehab with him, surgery after surgery, and it just confirmed that thought. In nursing school, I did a rotation in cardiovascular in ICU, CCU, and fell in love with all things cardiac. So just confirmed that I am 42 years in.
Wow.
And cardiovascular nursing and leadership. So it's a life
in the
passion.
right place. Yeah, right place. Oh, Jim, what about you? Do you have a story, that aha moment for you?
Yeah, I probably felt something similar at a young age, watching my dad help take care of my grandmother, which kind of got me interested in healthcare in general. And through high school and then into college, I was kind of drawn to medicine and taking care of patients. I started off on the clinical side, doing cardiac and vascular ultrasound, got into leadership probably, 20 years ago.
Wow. All right. Both of you caretakers, young in life. And so just kind of fell in line with what you've been able to accomplish. Susan, let me ask you the first question. Can you describe your structural heart program and its relationship to other cardiac systems in the service line?
Sure. So our structural heart program really began over 9 years ago. And as such, it started out with a very high CV surgery leadership component. And we had 2 primary cardiology groups that we worked with at that time. So that being said, I think we got the best of both worlds. So we really have a true partnership with cardiac surgery and our cardiology groups. Those 2 groups came together and became one cardiology group. We've really been able to streamline that across the system. At almost the same time, we really had a robust heart failure program begin developing, and that would be all the way up to left ventricular assist device implantation. And when we see aortic stenosis and heart failure, they work hand in hand together to move back and forth between those different specialty groups in cardiovascular. And then our teams work across the entire hospital in a tertiary care hospital. So lots of interaction with different groups.
Sounds like the perfect timing when everyone was kind of coming together. How much has your program grown in recent years?
Gosh, it's really grown a lot. We sit in between 2 other centers who do the same procedures, but we have gone from, 20, 30 TAVR procedures. And now we roughly live at about 120 to 130
Wow.
a year in just TAVR.
Wow. Much needed, obviously,
Much needed.
as well as you see that growth.
And expect more growth as TAVR has moved to lower moderate risk. We're starting to see those referrals come in. So
yeah, which we'll talk about that in a little bit because I
Yeah.
think that's important when we talk about that risk. So Jim, this is for you. When we're talking about this low to moderate risk, one factor that comes up is the difference between DRG 266 and 267. So can you explain that difference from your perspective?
Yes, the DRG codes for the TAVR procedure is 266 and 267. 266 is used for patients with MCCs or major complication with comorbidities. And 267 is used for patients without the MCCs. And patients with MCCs are seen as a tougher patient to care for. And it reflects in the reimbursement, which typically is about $10,000 more than a 267 procedure.
Now, in the data, which I think at MedAxiom we find is so important, what disparity do you see regarding acuity capture that demanded this further examination?
Yeah, early on in our program, we always kept hearing the doctors talk about how sick the TAVR patients were. But we felt like from a billing perspective, a lot of the patients were going out on DRG 267, which kind of represents more of a less sick type patient. So that kind of really got us to want to do a deeper dive and trying to understand what that looks like. So it led us to create a team of a whole bunch of different individuals, CDI, coding, physicians, coordinators, APPs, and also the vendor. I mean, vendors have been key to keeping us educated on all these different procedures. At the end of the day, what we got out of that was a lot better product when it comes down to documentation for the patient, a clearer picture kind of for coding as they're trying to figure out how to code these things. And then more importantly, at least for me on the business and side of it, the billing and capturing the max that we're able to capture for this population.
Which is crucial to any type of growth or progression. Susan, according to an American College of Cardiology report, in 2019, the first year that TAVR was FDA approved for low-risk patients, this population made up 11.5% of all TAVR patients. So important to know, kind of to Jim's point, considering the importance of maintaining clinical quality, can you explain why the notion that lower risk patients aren't as sick and why that's really just a myth?
Sure, at least I hope I can. The way I look at this is that I think in general, primary care, the general public thinks that because a patient's younger and they have this disease, that there's a wait time and you can wait and tackle this later. But it's really not that case. The myth is if you have aortic stenosis, you need to be in care at that time. So with that being said, I think it is so important that we look at those patients as their chances for comorbidity and mortality are the same. We're talking about a surgical risk, not a risk that patient can live with that disease forever. So from a quality perspective, getting those people in, making the right decision. And I think that having the surgical team, the cardiology team to evaluate that risk and individualize care for that patient is so important. Low risk, high risk, it doesn't matter. Aortic stenosis still kills.
Yeah, it's serious. And
it's serious.
With that collaborative care, you can assess that. What did you and your leaders do to verify that your clinical documentation integrity team was appropriately capturing TAVR patient acuity?
So Jim referenced that a little bit. And when he mentioned that we, met with our coders and our CDI, we actually brought that into a monthly meeting where we brought our team together and we actually sit and talk about new CMS guidelines. If there's new procedures that are out, we provide education to our coders. So if there is a new product or a new valve or a new way to document, we actually bring in folks who are experts and talk to our coders and CDI. And on the flip side of that, they tell us what we're missing in our charts, so that we can go back to our providers and actually pull them in. It really is a collaborative both ways for us, so that we capture the right acuity. We also are fortunate to have 2 nurse practitioners that work with our TAVR patients. So very important on the front end when they capture. That's been significant for us in terms of training a smaller group of people to actually document everything that needs to be documented on these patients. So that was another piece. And also looking at templating in our EHR was important. So all of those things kind of help serve us well.
Right. And Jim, you mentioned you're, really interested in obviously the business side of all of this. So let's talk about, that third party audit. What were a few insights gleaned from it from the business perspective?
Yeah, we had this third party come in and review all of our cases. And we figured out that they recommended about 8 cases get downgraded to a 267. But we brought those cases forward to the clinical team. We reviewed them. We talked through them with CDI, and we found the documentation in the chart to decide to continue to bill at the 266 level.
Thanks. I mean, with the audit, it kind of confirmed you guys were on the right track.
Even at our one of our meetings yesterday, the coding team shares those ones that the insurance companies felt like should get down coded. And so they're sharing all those cases with us. We're going to sit and show them to the providers. And I think it's, again, important to continue to challenge if you feel strongly that the patient's acuity is truly falls in a 266.
Yeah, that certainly benefits the patient for sure. All right, well, that sounds like an excellent place to pause. We have a lot more to discuss, but we'll have a quick message for our Heart Talk listeners, and we'll see you back here in just a minute. You hear the term care transformation a lot, but what does it mean exactly? Care transformation is redefining the way consumers buy and use healthcare by developing new products, treatments, and business models that integrate separate healthcare organizations or activities. MedAxiom understands that moving the needle in CV care is not simple. It takes vision and leadership, and it requires bridging technology, innovation, and care delivery. MedAxiom experts are helping programs across the country shape the future of cardiovascular care delivery. Through education, organizational performance solutions, and advocacy, we are evolving disease management, innovating virtual care, driving the data revolution, and redefining access and team-based care. Let's transform cardiovascular care together. Get started at medaxiom.com/care transformation. Welcome back, everyone. We have been talking to Susan and Jim about how they standardized acuity capture in their structural health programs. So Susan, take us back to when your group had just successfully undergone the audit that confirmed your team was capturing patient acuity appropriately. Now, we know it takes a village to ensure quality care is standardized across the service line. So can you describe what steps you and your team took to collaborate with other Prisma cardiovascular programs?
Sure. As Jim was referencing with the audit, it was an aha moment for us. And at the same time, we are very fortunate that we have a sister hospital in our organization who does a lot of the same volume, a lot of the same type of patients and work. And so we had a forum through the service line to actually share our experience. And as we did that, we really worked on standard care. We were able to bring providers together. We were able to talk with our counterparts in the other hospital to really start discussing all of the things that we did and really start talking to them about what they do. So for us, that was a win-win. And so just really being vulnerable, being transparent, and keeping our ears open to hear good work from them as well.
Yeah, I can hear the smile in your voice. That's a good feeling. I know.
Yeah.
Would you describe this process as bi-directional learning?
I absolutely would. I think we pride ourselves in being lifelong learners and a learning organization. I also think when you lay out your vulnerabilities, it opens that pathway for them to open up to you as well. So a lot of minds doing the same work are a lot better than two minds doing that work. So it also gave us opportunities to pull in our coding partners in the upstate. So great work on all fronts and a lot of learning going back and forth.
Yeah, Jim, let me ask you, sometimes you're on the same page, sometimes you're not. So what are maybe some of the barriers or pain points you encountered while working with your sister hospital and operationalizing appropriate acuity capture across the service line?
Change is tough for any system. I think the beauty of a good service line that Susan just described is we got to be open and prepared to adopt workflows that are going to work best for the patients. And so I would say some of the barriers, one was probably we were ahead of the game when it came to the cardiac coders. We had worked hard to collaborate and create that meeting. And so what this did is it allowed them to collaborate with our sister hospital and really start to share some of the best practices that we had created here at our hospital. One of the other challenges we had is, we were on Cerner. We had built what we felt like was a well-oiled machine around TAVR. And then we flipped over to Epic, which was their system. And so we had to collaborate together to, even though the workflows were slightly different, it's how do we ensure that we embed all the best practices on both sides to make sure we take care of the patients the best we can. Ultimately, at the end, I would tell you, with this collaboration, we moved the needle. It just happened to be a couple of years earlier, but we're seeing the needle actually move across the entire system. So it's good to see that good collaboration among everybody at the end has made a big difference in the overall finances of this program.
Slow and steady, and eventually you get there, right?
That's right.
Susan, I think I know the answer to this, but maybe did you receive any support from a particular industry partner or vendor? And if that is the case, what happened with that?
So we absolutely received support from our vendor, and I would tell you that it's been invaluable. They not only see our program, they see programs around the country. So as you need to network, as you need to talk to other systems, they make that possible. One of the ways they do that is through their healthcare leadership forum. Both Jim and I attended, and it just adds questions. You hear best practice. It's really stimulated us to try to move to the next level. I think the other thing that we've done that's been very valuable is we've actually met with the vendor on a quarterly basis to look at our data and just to have that looked at again by another party and see what they see. That's been tremendous for us. I'd also say that in healthcare, we all know that we have staff moving in and out. We've changed some of our structural heart coordinators and their support in trying to help us find ways for those people to train, even if it's online networking. It's just invaluable. So just being open to share and network has been tremendous.
Yeah, and Susan, let me ask you, as we kind of drive this home and stress the importance of this, but at the end of the day, what are the risks of improper patient acuity capture? And then again, maybe sum up some of those benefits when it's done right.
I would love to just talk about the clinical perspective. So in my mind, when you start driving adequate documentation and you set that patient up to have the best outcome because it's transparent. You have that from a surgical standpoint, from a cardiology standpoint, from the nursing, the ancillary staff standpoint, and that documentation moving with that patient through that continuum of care is invaluable. And I think really gets the best outcome for that patient clinically. And I'd love for Jim to share how he feels about the financial aspect. That's his area of expertise. But Jim, I'd throw that back to you for that piece.
Yeah, thanks, Susan. There's really a huge financial risk. We look back to when we were not capturing the acuity the best. I mean, we struggled a little bit as a program from a financial standpoint. And I think through this process, we've been able to prove that if we get the documentation right, we get the right people in the room, we work through the toughness of coding and reimbursement with the payers, that it can be a profitable program. And that's kind of where we are as a program. And I think but there's a huge risk is if you're not doing this, that it can definitely be tough to the bottom line for a hospital.
And in the end, I mean, to both of you all, the patients, they have access to this and it's profitable and it's working, it definitely shows that it puts the patient first.
I think you're absolutely right, Melanie. It is all about the patient. When we are not capturing that acuity appropriately, it can affect what our outcomes look like to the public. We want the public to understand that these are sick patients. And we want, as public reporting continues, we want them to understand that we are providing the right care for the right patient at the right time, and that we are taking care of a very sick population and doing a good job. It really affects our outcomes and our quality. So again, not just about finance, includes finance, but all about the patient and getting that patient the care they deserve.
Yeah, it's really good work. Thank you so much. Patient first, right?
Right.
Yeah, Susan, Jim, thank you so much for sharing your time and your expertise with us on MedAxiom Heart Talk.
It's been a pleasure.
It has. We appreciate it.
Well, that is it for this episode. If you liked it, please share with your colleagues and let them know that they can subscribe to MedAxiom Heart Talk on Apple, Google, or wherever they get their podcast. Also, if you'd like to send us a note directly or maybe suggest a topic, email us at hearttalk@medaxiom.com. Thanks so much for listening.